It's a very interesting topic. In fact, Dr. Rajlakshmi has actually set the stage well for a microbiologist and what the clinician expects from the microbiologist. It's not only the ID. So we are actually fighting the next generation war, I think, when it comes to microbiology. Last 2 years, for the lab, for the clinicians, everyone, it's been really, really hectic. But let's look at what solutions we have to manage them. So I start off with a case actually. This is a very, not something that we don't see, it's very common. A 60-year-old male admitted for elective CABG surgery. He has plenty of comorbidities, has had multiple hospitalizations in the past 3 months. Post-surgery, day 2, he's fine, he's extubated, he's clinically stable, but he's in the ICU for further monitoring. Of course, his cough reflexes are weak. He's on physiotherapy for the same. Day 5 post-op, he develops fever, he develops hypotension and breathlessness, and there's a patch on an X-ray. Now, this is something that is common to the ICU setting and a person with so many comorbidities. A hospital-acquired pneumonia is suspected, and he started empirically on IV meropenem 1 gram 3 times in a day. He's intubated, specimens are sent for culture. Of course, there's no improvement in the next 48 hours, and the patient passes away on day 8. And the blood culture report is, meaning on day 5 itself, on day 6 itself, the blood culture was positive of a gram-negative bacilli, but more than that, nothing else could be done on that day. And on day 8, it was reported as Klebsiella, which is resistant to meropenem. This is not uncommon to us. It's very disheartening that every day in the morning I have to, report probably out of 20 cultures, 8 to 10 cultures which are actually like this. And this is what is called as a superbug. Okay, and there are plenty of such superbugs that we have that have been documented, known, for example, and all of these are multi-drug resistant, and the main constraint is that we do not have antimicrobial agents to treat them. And that, coupled up with the fact that we have very few antimicrobial agents being discovered. There are no new ones that are coming up, and the last 20 years probably have been really dry on this field. These superbugs are really causing a problem, and particularly in a country like India, it's Klebsiella, Acinetobacter, Pseudomonas, Enterobacter species which cause the major problem. Staph and Enterococcus are more of the bugs of the West. And for this reason, that you don't have antibiotics, WHO has in fact put up a priority list where it describes critical pathogens high and medium. And what's more important here is, or rather what's concerning here is, look at pathogens like Helicobacter, Salmonella, Campylobacter, Neisseria. These are all community pathogens. They are not there in the hospital. They are not there in the hospital environment. So we have a whole lot of community hospital pathogens that are multi-drug resistant, and then you have a whole lot of concerning pathogens in the community as well. So overall, AMR is a big problem to us, and something needs to be done. And in fact, we called AMR as a silent pandemic. Recently, there were some reports in Lancet on this, that it is a silent pandemic. Is it really silent? I don't think so. There's this new report that was published in Lancet in Jan 2022 from the Global Antimicrobial Resistance Collaborating Group, and they looked at global burden of bacterial resistance in 2019, and in fact they found that 4.95 million people who died in 2019 suffered from at least one drug resistant infection, of which 1.27 million deaths were directly related to AMR. So is it really a silent pandemic? I don't. Once the COVID pandemic probably recedes, we are full-fledged into another one which we really need to give significance. That's about AMR. But the other thing that happens and that draws our attention is the current pandemic that is going on, and I'm sure there are many others that are going to come in the future for which we have to be prepared. So be it the novel coronavirus or be it the various variants that have caused different ways or waves, or the other brother and sisters of the coronavirus that have caused problems earlier. Trust me, we are going to have viral epidemics, pandemics, and new emerging and re-emerging organisms coming up to give us trouble. And therefore, microbiology diagnosis is absolutely needed to wage this war against the next generation pathogens that we will be facing. And in fact, Dr. Rajlakshmi very beautifully pointed out how microbiology should play a role. And in fact, I think microbiology has a central role in the management of critical infections or management of infectious diseases per se. So whether it is confirmatory diagnosis, supportive diagnosis, prognosticating based on cultures, or even providing with therapeutic options or the duration of therapy, microbiology certainly plays a central role. Unfortunately, there are some problems in the lab. We are, very slow on turnaround time. So as she said, it takes 3 hours to maybe upload a report and maybe 48 hours to actually put out a DST. A lot of empiric use or misuse of antimicrobial agents are because of this slower detection. And there is plenty of emerging and re-emerging and novel infections that we face, and all of this causes delay in the diagnosis, morbidity, mortality, rapid spread, as we saw with the coronavirus, and the menace of AMR continues. So what are we supposed to be really doing? We really need something which is 5G speed. We can't be working on 2G and 3G speed. We need something that is 5G. Dr. Rajlakshmi once again talked a lot about MultiTOF. She talked about the film array. All of these are, minutes to hours, they give us results. And this is what is required. In fact, if you look at the pre-molecular era where we were doing blood cultures, detection and then sensitivity, it would take almost 3 to 5 days. But we now have technology which can help direct testing from blood of a patient who is suspected of sepsis and give you results in about 2 to 6 hours, not only identifying the organism, but also even detecting resistant mechanisms. And these detection of resistant mechanisms are very important because you can give targeted therapy. The whole thought process now is moving towards precision medicine and targeted therapy rather than, empiric therapy. Of course, we want to shorten the duration of empiric therapy as much as is possible. So we are there when it comes to rapid diagnostics. We are reaching that phase. And COVID has brought us to a lot of next-gen technologies also. We never thought, at least I never thought, that a PCR would be reported in 30 minutes. And in fact, with the film array, my laboratory does the film array 24/7. Even people who are not posted in microbiology have been trained to do the film array 24/7. So it's very, very easy. And similarly, something like a POC PCR, which is giving you results of whether coronavirus is present or not in about a matter of half an hour, or something like the LAMP test. They are really technologies that are going to be, taking us forward. And while these have all come up during the corona era, trust me, we are going to have syndromic approach. Dr. Rajlakshmi mentioned about syndromic approach of diagnosis at the bedside. The microbiology lab of tomorrow is going to do syndromic approach diagnosis at the laboratory, and these methods are going to be rapid, meaning few minutes to a few hours. They'll have more than one pathogen. Today we have coronavirus, but Gene Expert is going to get a test which will have corona, influenza, and another RSV. So similarly, even this Acula is going to come up with a multiplex option. So these will be POCs, that is, there will be point of care tests which could be used in the emergency settings. It could be used in clinician offices, where you really require very little expertise and little infrastructure. I think that's something which is very important. Labs don't have enough space, and certainly microbiology labs don't have enough space. And setting up a PCR lab during the COVID pandemic, we've seen that it requires a particular concept when it comes to setting up a proper PCR lab. But these kind of tests or technologies do not require the 3-room concept, etc. They require little infrastructure space and in fact little capital budget also. And these are the technologies that we are looking forward in microbiology. And not to say that the cultures would be gone away. These are going to support our culture-based methods. In addition to the amplification techniques, I think sequencing is also coming up a big way. Whether it's WGS, that is whole genome sequencing, or it is metagenomics. We have a whole range of sequencers that are available, right from the ones which are huge and will take a lot of time, probably weeks to analyze results, to the ones that we have more recently. In fact, we have the Minion, which can be placed on the palm, and it will give you results in probably a day or two. So these are technologies that are available, and they are going to support us in diagnosis of infectious diseases. And I was very encouraged, in fact, this timeline really encourages me as to how we actually came to understanding the whole genome of SARS-CoV-2, which was an absolutely new pathogen, in a matter of 10 or 11 days after the WHO declared that this was a pandemic on 31st, this was a concerning pathogen on 31st December, and by 10th of Jan we had actually the whole genome sequence, and with this whole genome sequence did the manufacturers start working around, what could be the therapeutic targets, what could be the vaccines that could be made, what are the correlates of protection, and so on and so forth. So sequencing certainly is something that is now in future going to play a very important role when it comes to diagnosis as well as management of infectious diseases. So it would help in identification of new pathogens and drug resistant mechanisms. It would help in understanding the human microbiomes, and in fact the changes in the human microbiomes have actually been known to be associated with a lot of infection syndromes as well as non-infection syndromes. In fact, Alzheimer's has been linked to a change in the gut flora, and that was something very interesting. They help in strengthening epidemiological tracking. So all the variants actually have come into significance is only because of the constant epidemiological tracking through sequencing. They help with the discovery of new therapeutic targets and vaccines. And finally, I think they play a very important role, metagenomics especially, which is done through sequencing in adopting the One Health approach. And WHO's theme for 2022 is actually related to the One Health approach, where it says our planet, our health. So this One Health approach actually recognizes the connection between the health of people, animals, and the environment, and this is how we are going to move ahead, because if we forget to look at this, there will be plenty of emerging and re-emerging zoonotic infections. There will be plenty of new variants of pathogens that are jumping across species, be it man, fish, animals, and so on. And AMR will continue to be driven if we misuse our antimicrobial agents in these industries. So the One Health approach is going to be the key to move ahead and reduce infections and help with management of infectious diseases. So finally, to summarize, the recent pandemic has actually consolidated the role of microbiology-based diagnosis. Early and rapid diagnostic tools are now available, but we still need to work around genomic methods which will be adaptable to the clinical microbiology lab. I can't have a sequencing technique which is going to take me 2 days to give me results. We need to work better on that, and the most critical element is going to be the turnaround time. And antimicrobial stewardship, diagnostic stewardship, and if I may add, infection control stewardship would be the 3 pillars with which how we are going to manage infections. And certainly as a public health measure, it would have to be the One Health approach. Thank you so much.
Yeah, thank you so much, Dr. Aruna. It was always a pleasure listening to you. It was wonderful that you took us through, very simply through, the entire, scenario of what is happening now and what is it for the future. Right? It was really, really nice. Taking us from the drug resistant as a key, as well as the emerging diseases, as well as what is coming in with the pandemics that we've already seen. Definitely, I would say, even with a little bit of experience like what I share with what Dr. Aruna had mentioned, the last 2 years have been a great one for the laboratory sector, particularly more so for microbiology and molecular biology, because almost all labs across the country have been now equipped with molecular testing facilities, and thanks to enable accreditation programs along with ICMR for equipping these laboratory with quality processes so that they could do exactly what is required. Even in the remotest places, they would do a good testing. And I was just sharing with the team in the afternoon that how this last 2 years have revolutionized the way the tests have been done. I think Dr. Aruna was telling that, can you believe some tests are done in 30 minutes? There are tests done in 12 minutes also. The Abbott ID does that. You know, it's so good, so easy a system where you have to just keep it in an office room and you don't require this four-room, system of having a unidirectional flow. You just need two areas, and like Madam said, you don't need highly qualified personnel with great expertise and skills, to train them so much. This is so simplified. They need to just add the sample, put it into the slots that's been identified, and then carefully just look for the results and then validate them. So that simple is testing, and thank you for telling us and taking us through that particular part of it as well. And drug resistance, definitely we all are worried about, and testing with molecular has been very, very useful, and next-gen sequencing definitely is the future. And if minions are going to come into our hands, definitely gets the targeted therapy that you mentioned. We know the bug, we also know the resistance, we know what antibiotics to give. I think there are some systems, like just an example of what is there now with the TB. We were also discussing with Dr. Rajlakshmi in the afternoon about a system where it identifies the drug resistant. 10 different drugs are identified for tuberculosis in just about 80 minutes. Earlier, we need to wait for about 8 weeks. No, 80 minutes. So we used to wait for 8 weeks for these cultures to come, then put up for susceptibility testing, and then identify. Now we do have these, CBNAT techniques where it's cartridge-based assay, where earlier we used to have tuberculosis identified and look for RIF resistant alone. Now we have 10 different other genes also identified. You can look specifically for INH, and then the entire of your second line injectables. All of these in 80 minutes is as good as you know that the person is positive for TB, and in 80th minute you know what antitubercular drugs to give. So that is what we are at now, and future is definitely looking bright for us in microbiology. And adding on to what Dr. Rajlakshmi said, we need to communicate, and microbiologists to the clinicians to the microbiologists, and also the epidemiologists, so that we know what's new and what's coming up, so that we are aware of the newer pathogens, the newer bugs that's emerging, and we target our therapies and treatment. Thank you very much to take through the journey.
Thank you. Any questions?
Thank you, ma'am, for the wonderful talk. A lot of promise with gene-based diagnostics. As an ID professional, I'm John Paul at Sparsh Hospitals. My only concern every time I get a gene-based report is, as against a culture, we are sure that it is a viable bacteria which is multiplying there, and we are fairly sure it is the pathogen. Where, as against a gene-based report which comes online, I'm always a doubt two things. Can a commensal be picked up? And how can we, definitely there is some amount of clinical correlation that we have to do. Minus that, is there any way to pick up these two? Two, is there a data on half-life of persistence of these genetic materials in circulation from someone who has recovered from a recent infection? So are we ending up treating a previous episode or a commensal colonizer with this report in hand?
So I think your concerns are very, very valid, in fact. And no test can be put in as a test by itself. There has to be clinical correlation. So we, in fact, when I'm ever reporting a pulmonary PCR, meaning a lower respiratory PCR, we almost never reported, or rather simultaneously do the gram stain, the Zn stain, before we have reported it, because that panel does not have TB, which is the most important disease in my country. If I were to miss out on mycobacteria on a sputum sample and then report some kind of things there, it's not going to work. Similarly, your comment on commensals also is very, very valid. That's precisely the reason why the microbiology needs to pick up the phone, communicate at the other end to find out what could be the pathogen if multiple pathogens are detected. Fortunately, some of these tests have a quantification. For example, the lower respiratory panel, the bacteria have a quantification associated. So we don't report anything which is less than 10 raised to 6, even if you have 10 bugs that are detected. Only the ones that are 10 raised to 6 and above, and there was a recent French paper on this as well, which said that 10 raised to 6 and above correlates with the cultures, and that's what we have also observed at our setting. So we almost never report without understanding what is there on the other side. So these tests actually probably helps us pull our socks and communicate. What we have all mentioned about communication, which has to be two-way, I think the microbiology lab will be forced to communicate from at the clinical end if we were to report these well.
Just to adding on, see, suppose you have your organisms are still there and therefore it is still detected. There is no half-life for it to say this is when it's going to be removed. But over a period of time, definitely it is not going to be there. The dead bacilli is not going to be there in the system. Like Madam mentioned, gram stain or any smears would tell us what is the clinical picture, and also any inflammatory cells, the presence of certain bacteria within the cells. All of these gives a clue that it's a pathogen and not a colonizer. So these are some additional points that we would gather, and definitely putting for a culture when you add on. See, but you have started a therapy, so therefore it just adds on. But you have definitely made it much easier. Your clinical decisions are made much easier. Your patients are getting better. So your communication will definitely tell us what is the present condition of the patient and how is it going to help from our side, from as microbiologists.
I think the pretest probability is very, very important, particularly when it comes to CSF specimens where you can have silent viruses like CMV, your HHV6 being picked up as well. In fact, I think Clinical Infectious Diseases in 2018 or 19 had an article on HHV6 being picked up as a very common pathogen from a cohort in US, and they found that they were all silent bystanders. So the pre-test probability with which you send us the specimen and how we report is going to be the key, and further the communication. Thank you. Thank you. Thank you.